Congratulations, you've made it to chapter 29. We're going to be talking about management of patients with complications of heart disease. So our objectives here are to outline some common complications of heart failure. We're going to be talking about how to manage patients with these complications related to heart failure, and then also a little bit about how to manage patients with thromboembolism, pericardial effusions, and sudden cardiac death. Okay. Alright, so just a brief little review for heart failure. I cannot emphasize enough how you have to have a really good working knowledge of heart failure, understanding of heart failure, how it develops, how to manage it, right and left signs and symptoms, how to differentiate between the two. This all should be reviewed for you. Cardiac output is determined by heart rate and stroke volume. Okay. Preload is the volume of blood that is returning into the heart, or the filling volume. Okay. Afterload is pressure. It can be systemic resistance or pulmonary resistance. That's PVR. So afterload can be SVR or PVR. And then the last thing that plays into cardiac hemodynamics is contractility. The force of contraction, the squeeze. Okay? And that is directly determined by the health of the myocardial tissue. So if you have good, healthy heart muscle, you're going to have good contractility. If you have weakened heart muscle or poor perfusion, from an MI or whatever, then the contractility lessens. And when contractility is less, that reduces cardiac output and leads to heart failure. Okay? Alright, so the first complication of heart failure I want to talk about is cardiogenic shock. That is a decreased cardiac output that leads to inadequate tissue perfusion and initiates a shock syndrome. Okay? Cardiogenic shock happens when the heart's ability to contract, its ability to pump, is impaired. And it leads to cardiogenic shock. It is a form of shock, but it is related specifically to damage to heart muscle. Okay? So the causes, it can be coronary or non-coronary in nature. So coronary causes of cardiogenic shock would be MI, the direct result of, an acute MI leading to lack of oxygen and heart muscle damage, and then the patient goes into cardiogenic shock as the result of that. That would be a cardiogenic type or coronary in nature. Non-coronary causes are end-stage heart failure, tamponade, PE, cardiomyopathies, or dysrhythmias. Those are non-coronary causes. So really, if you just think of it, MI would be the only one because it's lack of blood flow. Everything else, you might have adequate blood flow, you might have good circulation through the coronaries, but there are other reasons that the heart muscle is not contracting appropriately and the cardiac output is decreased. And there is such a profound reduction of cardiac output that it initiates a shock state in the patient. Okay? So, manifestations are just symptoms of heart failure initially, right or left, depending on what the problem is. So if it's coronary in nature, depending on which coronary artery is involved, that's going to determine whether or not we have those right or left sided heart failure symptoms. And then eventually you're going to see your patient develop shock-like symptoms. And I know that we have not really talked about shock yet, but you can read up on this in chapter 15. There is a section about shock, and the the symptoms and hemodynamic stability, instability that goes along with that, okay? And this chapter, these pages are specific to cardiogenic shock. So most of the time you're going to see cardiogenic shock develop as the result of very, very severely impaired left ventricular function. So that can either be from an MI, it can be from hypertrophic cardiomyopathy, dilated cardiomyopathy, could be from tamponade, it could be from an episode of VTAC or VFib. You know, something that impairs left ventricular function or damages the left ventricle so severely that the body just cannot compensate anymore and the patient goes into this shock state. Medical management, of course, the goal is to treat the underlying problem because shock is always a symptom. Shock is not a disease process in and of itself. Shock is caused by something else. So our goal is to treat the problem. So we definitely want to, priority-wise, correcting the underlying problem is the key, but our main priority is improving oxygenation. That's number one, okay? So if we're talking about priorities, we have to limit muscle damage, preserve our healthy tissue, because time is muscle. So in order to limit damage and preserve healthy tissue, we've got to, first of all, improve oxygenation. Secondly, we have to reduce additional demand on the heart. So we've got to help the heart work smarter, not harder. Then we want to restore perfusion, okay? So we can improve oxygenation by giving oxygen, okay? That we can do right off the bat. We can reduce the demand on the heart with medications. We can do that pretty quickly. Then restoring tissue perfusion, that's where we get into heart cath, stenting, angioplasty for those coronary causes, and then correcting the underlying problem. That might be for the non-cardiac, non-coronary causes, that could be valve replacement, treating a dysrhythmia. If that lethal dysrhythmia was caused from an electrolyte imbalance, then it would be correcting the electrolyte imbalance. That's the correcting that underlying problem. So our goals of therapy are, arranged in order of priority, beginning with let's improve oxygenation, let's reduce the demand on the heart, then we can work on restoring tissue perfusion and correcting that underlying problem. Okay? We have to limit muscle damage, preserve the healthy tissue, improve contractility, reduce afterload. Time is muscle. We need to help the heart work smarter, not harder. Some of the medications that are going to be used, initially oxygen, of course. That's the way to improve oxygenation. Morphine is, the whole MONA, morphine, oxygen, nitroglycerin, and then aspirin, maybe not so much aspirin in this situation, but oxygen, morphine, because it dilates, opens up those coronary arteries, helps to get more blood flow in there, and it also helps with pain. Nitroglycerin is going to do the same thing. It's going to help to dilate and get more blood flow, reduce afterload. Also might give diuretics if the patient, you have to remember we're talking about complications of heart failure. So if it's a right-sided heart failure and the patient is severely fluid overloaded, or even if it's a left-sided heart failure and they're very fluid overloaded and they've got those respiratory symptoms, then we're going to be giving diuretics to help eliminate that excess volume. Positive inotropes to increase contractility, improve contractility. Can be using positive inotropes in combination with antiarrhythmics if needed, or vasodilators if needed. In a shock state, one of the important things to remember about any kind of shock is that as the body induces a shock state, prostaglandins are released into the bloodstream. And in general, prostaglandins cause vasodilation. Okay? So, initially, in this cardiogenic shock event, you might have a patient who is vasoconstricted, and we might give them vasodilators to cause some vasodilation and reduce afterload. But as this shock state progresses, the prostaglandin release will actually vasodilate your patient, and that's where all the shock patients, they drop their blood pressure. They become very hypotensive because of the release of prostaglandins. So it's kind of an incremental, it happens over time. Initially, the blood pressure might be very high. You might need vasodilators. You might need nitroglycerin to reduce afterload and help efficiency of the heart. But if it progresses far enough and the patient becomes sick enough, you're going to begin to see the blood pressure drop, and we won't be able to use things like nitroglycerin anymore. We'll have to shift over to vasoconstrictor medications such as dopamine or Levophed, something like that, to maintain that vascular constriction. Okay? So it's a time thing, and it kind of depends on how sick the patient is. So if you have a patient in cardiogenic shock and their blood pressure is good without any support, then that's a good thing. If they're to the point where their blood pressure is starting to drop and getting low, then you know they have progressed in that cardiogenic shock event. Okay? We also could be initiating IV inotropic agents. You know, we've talked about beta blockers as inotropes. Those are actually, I think, negative inotropes, but your IV stuff would be dobutamine is the best one because it increases contractility and it doesn't increase the heart rate. Dopamine is an inotropic agent. Dopamine is dose dependent. Low doses of dopamine can be used to increase contractility. Low doses meaning 2 mics per kg per minute to 8 mics per kg per minute are really good to help the heart pump very efficiently. And if you help the heart pump more efficiently, you improve cardiac output, then you get better perfusion. So it also in turn will increase renal perfusion and improve urinary output. And that's kind of the low dose of dopamine. 2 mics per kg per minute to 8 mics per kg per minute is called low dose dopamine. You can get some really good improved contractility, improved cardiac output, but the downfall to dopamine is that it also will increase the heart rate. So you might get a better cardiac output, but you're going to get some tachycardia along with it. Not all patients can handle that. When you get doses greater than 8 mics per kg per minute in dopamine, it becomes a very potent vasoconstrictor. So dopamine kind of has 2 different uses depending on the dose. The higher doses cause potent vasoconstriction, in which case is going to increase your afterload, increase your systemic resistance, raise blood pressure, and further raise heart rate. Okay? So when we're talking about our inotropic agents, our positive inotropes and vasopressors, initially, remember we want to reduce afterload. That's where those vasopressors come in. And then as it progresses and all of the prostaglandins are released and blood pressure begins to drop, then we're going to move into those vasoconstrictor medications. You might be using a combination initially. You might be using nitroglycerin to reduce afterload, so you might have them on a nitro drip to reduce afterload, and they will also be on low-dose dopamine or dobutamine because of the inotropic effect. So you're improving contractility, improving cardiac output, and vasodilating to reduce afterload, which all helps the heart to be very efficient. Okay, remember, it's all about being smarter, not harder. So if you go into clinical, you go with me especially, and Ms. Humphrey, if you go into the unit and you see a patient that's on nitroglycerin and dopamine, the first thing you need to look at is the dose of the dopamine. What are they using it for? And think about what's going on with that patient, okay? Because yeah, they seem like they're opposites. They're doing the opposite thing, but they actually use them together to achieve a very specific purpose. Could also see circulatory assist devices in your patient, and that is the intra-aortic balloon pump. Occasionally you will see one of these in the unit. These patients that have a balloon pump are very sick. So a balloon pump patient will only be in ICU, okay? And we're going to talk about balloon pumps in just a minute. But remember, the overall goal of therapy for cardiogenic shock is to, improve cardiac output, improve muscle contraction, so that we can preserve tissue, we can preserve healthy tissue, and limit damage. Okay? We want the heart to work smarter, not harder. And when we talk about the balloon pump, specifically what it is, it's called a counterpulsation device, and it's used to augment the pumping action of the heart. Okay. Now, a lot of this you may not be able to understand on the audio lecture. We can get into good discussion in class about it, and it might be a little easier to understand. But I'm actually going to go forward to the next slide to the picture. Okay? Okay, so when I talk about an intra-aortic balloon pump, I wanted to reference the picture. Actually, it's done much like a heart cath, and what they do is they go in here in the groin, right here, and they actually feed up through the aorta, and this part right here is a balloon, okay? And it sits, it's like a little sausage on a stick. Similar to what we talked about with angioplasty, but it's a little bit bigger, and it actually stays inside the patient's body. So they position this balloon just below the aortic arch. You can see how this starts to curve right here, and as it begins to straighten out, the very top of the balloon is positioned right at the top, right under the aortic arch, and it extends down in the aorta. Now the goal here of the positioning, this balloon pump has to be somewhere between the aortic arch and the renal arteries. That's the important part. If the balloon migrates up too high into the aortic arch, then it's going to obstruct blood flow going into the head or going into the subclavian. Okay, you see how these branch off right here? So we don't want to obstruct this in the aortic arch, and we don't want to be down here too low at the level of the renals, because then we cut off blood flow to the kidneys, and that is never a good thing. So this balloon has to rest between the aortic arch and the renal arteries. Okay, now the theory or the mechanism behind it is that the balloon is threaded in, it's positioned, and it is called a counterpulsation device. So what that means is that it inflates and deflates, and the balloon actually does inflate and deflate. It's timed in correlation with systole and diastole, but it's counter to heartbeat. So when the heart contracts on systole, the balloon is deflated. And that's because in systole we're pumping blood out, and we don't want to obstruct that blood. We want the blood to be pumped out of the heart through the aortic arch out into the body the way it's supposed to. Then when the heart moves into diastole, into the resting state, then the balloon is inflated. Now when this balloon inflates, it actually forces blood back up into the aortic arch, and then in the aortic arch it's going to go up into the head and into the subclavians, and then also remember what else gets perfused during diastole is the coronary arteries. So during diastole, when that balloon is inflated, it forces blood not only into the arch and into the head, but into the coronary arteries. So it actually helps to augment or improve coronary artery perfusion. Okay? And that's, the balloon is inflated during diastole or the resting state. Now, the other fun thing about a balloon pump is that, like I said, on systole, when the heart contracts and is pushing blood out, that balloon deflates. Well, as the balloon deflates, it actually creates almost like a vacuum, or in the blood. It kind of almost sucks the blood out. So it enhances, or it augments the pumping action of the heart. The heart, it's helping the heart when it contracts to be able to pull that blood out and get it out to the body where it needs to be. So it's a counterpulsation device that's used to augment contractility, augment the pumping action of the heart. It's positioned below the aortic arch and the renal arteries. Its purpose is to decrease afterload and decrease the workload of the heart, which improves cardiac output. As it's deflating, like I said, you've got the heart contracting, and as the balloon deflates and helps to get the blood out, it actually is reducing afterload. So that's one of the main goals of the balloon pump. Our responsibility in terms of nursing, and again, this is not something that you come out of school being expected to do. This is advanced training that you will receive if and when you go to work in an area that takes care of balloon pumps. But our responsibility is just to make sure that the timing is appropriate, so that our inflating is in diastole and the deflating is during systole. If we are trying to inflate this balloon at the wrong time, if we inflate the balloon during systole when the heart is trying to pump the blood out, then it's opposing forces meeting each other, and that just can be disastrous. So you can understand how you want timing to be done. The timing is all controlled by the machine itself. So and again, this is advanced training, so it's not like you have to understand how that part works. Your other responsibility other than the timing is just ongoing assessment of your patient. You have to look at their heart rhythm, their blood pressure, urine output, their mean arterial pressure. Those are all signs of adequate cardiac output. Their fluid status. You know, the bottom line, this machine is meant to augment cardiac output. It's meant to help it, enhance it. So if our heart rate is too high, if the blood pressure is too low, if urine output drops off, if the mean arterial pressure is too low, then those are all signs that we have poor cardiac output, so the machine is not helping. So timing is important to make sure that it is being beneficial, not detrimental. Alright, some nursing management things for cardiogenic shock. Of course, assessment. That's our biggest, most important responsibility, is our assessment. We're looking for changes, any subtle change in patient condition. That might be a slightly elevated heart rate. It might be a slightly, again, decreased blood pressure, changes in urine output, just any subtle change in level of consciousness. Subtle changes are very important. We also are responsible for making sure that they are responding to the treatments and the medications that are being implemented. So if it's a diuretic that we're giving, we've got to assess urine output. If it's a vasopressor that we're giving, we've got to make sure that the blood pressure or the mean arterial pressure elevates. If it's a vasodilator, then we're looking for lowering of blood pressure and reduction of afterload. So that's why it's so important for you to know these classes of medications and the effects that they produce, because you're going to be given the drug and then you have to make sure that it did what it was supposed to do. Okay? Another responsibility for nurses is to evaluate the outcomes, and then do we need to make changes? So it's a constant, ongoing evaluation and regrouping, replanning, making changes, making updates, or evaluating and saying, okay, good, this is working the way I want it to. We're going to keep on doing it. We're going to keep this medicine running at this rate. We don't have to titrate it anymore. Or the balloon pump, the timing is just right, and the patient is cardiac output looks really good, and so we're not going to make any changes to it. So thorough assessment, continuous monitoring, looking at rhythm and blood pressure and I&O balance, and making sure that all of our equipment is safe. If we've got all these invasive lines, if you have a balloon pump in place, you will have an arterial line, and in most cases you're going to have a PA catheter as well. Sometimes not, but a lot of times you will. So, and again, cardiogenic shock, we have a non-functioning heart muscle, and so a PA catheter will often be put in to help measure those pressures. So you're looking at your insertion sites, you're making sure that there's no bleeding and hematoma development going on, that they don't have signs of infection, because cardiogenic shock takes days to resolve. So these lines are going to be in place over a period of time. You must also assess distal perfusion. So if it's a femoral, a balloon pump will always be put in femorally. So you're looking at perfusion in the feet, because that is an invasive thing in a femoral artery, and so they could potentially have reduced perfusion to their foot. They could throw a clot. So you've got to assess pulses. You've got to look at cap refill. You've got to feel the temperature of that foot. A lot of times, especially with balloon pumps, the foot, the leg that it's in will be much cooler than the other one. Sometimes it'll even be a little dusky, and that is risk versus benefit, because you can live without a foot, but you cannot live if you don't have good cardiac output. So but you still have to assess for it. You still have to document any problems that you might see. All right, moving into thromboembolism, kind of moving out of cardiogenic shock and into thromboembolism. That is decreased circulation and an increased risk, decreased mobility and decreased circulation increase the risk of clot in patients with cardiac problems. Okay, so if you've got heart failure, that's why thromboembolism is a complication of end-stage or advanced heart failure, because with the advanced heart failure we have a reduction of cardiac output, we have reduced contractility, and so there is a greater chance of poor circulation and the formation of a clot. Because the patient has reduced cardiac output, they have reduced contractility, their activity level is reduced, their mobility is reduced. So that also puts them at risk for developing clots. So here you have a patient who actually has a double risk of clot formation. Okay? So we have the risk of intracardiac thrombi, clots as the result of AFib. If the patient's heart failure has caused an atrial dysrhythmia, specifically AFib, then they must be on blood thinners because they are at risk for an embolus. We will always diagnose thromboembolism, cardiac thromboembolism, intracardiac thrombi will always be diagnosed with echo. Okay. We treat with anticoagulants. If they have a known blood clot, then they're going to get loaded with heparin. They will be given a bolus. Usually the boluses are anywhere from 5 to 10,000 units IV push, and then they will put them on a heparin drip. When a patient is on heparin drip, we are going to do serial PTT studies. Typically every 4 to 6 hours we're going to be checking that PTT to make sure that the blood is thin enough that we're therapeutic, meaning it's thin enough to dissolve the clot, but not so thin that the patient bleeds out. So initially they're going to be on IV heparin, and then we will switch them over to PO Coumadin after we get the clot dissolved or small enough. Then we'll put them on Coumadin for long-term maintenance therapy. Now y'all need to go back and brush up on what is heparin, what is Coumadin, what are the labs that go with each one of them, how do you know those labs are therapeutic. So I've already told you that PTT is for heparin, but you need to know the lab values for PTT that say that it is therapeutic in nature. And therapeutic does not mean that the PTT is normal. If the PTT is normal and they're on heparin, then it's not therapeutic. Same with Coumadin. Coumadin is PT-INR, and you want therapeutic INR levels. So therapeutic INR does not mean that it's normal. It's got to be thin enough to keep the blood from clotting and forming an embolus. So make sure y'all go back and brush up on those. Okay? Another complication of end-stage heart failure is PE. We've already talked about PE extensively, so I'm not going to go into this in any depth. You know what PE is. You know what risk factors for PE are, how to prevent a PE. Pulmonary embolism related to heart failure comes from not that they have a clot in their legs necessarily. It can be a thrombotic event related, well, it is a thrombotic event related to reduced cardiac output. Okay, so where we had the thromboembolism was related to AFib, intracardiac clotting from AFib. Our PE is reduced contractility. It's from reduced pumping action of the heart as the result of the heart failure that forms blood clots in the legs. Okay, and we can directly relate it to the fact that the patient has severe, profound heart failure. So from now on in clinical, those of you in med-surg, when we have a patient who's end-stage heart failure, I'm going to automatically expect you to know that they are at risk for DVT PE. Now you know, to whom much is given, much is required. So our indicators of PE are the same that we've already talked about: shortness of breath, tachypnea, chest pain. Prevention, prophylaxis is the same. Our treatment is the same. We need to assess the patient, stabilize their respiratory status first, stabilize their hemodynamic status first, because I talked about before how profound PE can be. They're fine until they're not. We're hoping that the patient does not have sudden cardiac death, that they are still alive. In that case, we would initiate anticoagulation, thrombotic therapy, just like we did with the thromboembolism. We're going to load them on heparin. For anticoagulant therapy, we're going to load them up on heparin. We're going to be doing PTTs every 4 to 6 hours to make sure that they are therapeutic. Thrombolytic therapy is the clot busters, where they will actually give used to we did it systemically, where we would just give an IV clot busting agent, but now they have more targeted treatments where they can actually identify where that clot is, and they can go into the like the cath lab or through radiology, and they can actually administer TPA, is the thrombolytic drug, right directly on the clot, and that is safer for the patient because the patient's not getting that systemic dose of TPA. But we've got to stabilize them first, then you can expect heparin therapy and then possibly TPA. And then, of course, prevention is always best. We've got to educate them on prevention of future DVTs, because with a bad heart, with poor contractility, they're always going to be at risk. Pericardial effusion, we've already kind of talked about that too. That's just an accumulation of fluid in the pericardial sac. Chest pain, fullness, you're going to see pulsus paradoxus. That is characterized by a decrease in the systolic blood pressure by at least 10 millimeters during inspiration. So as the patient inhales, the blood pressure drops, and then as they exhale, it immediately goes back up. So that's that pulsus paradoxus, okay? So a collection of fluid, the normal amount of fluid, like I said before, was less than 20 mils. So patients with advanced heart failure, we talked about cardiac surgery, we talked about trauma, pericarditis, they are prone to developing a pericardial effusion. And that restricts the contractility of the heart. The patient will complain of a fullness, sometimes chest pain, but feeling just a pressure or a fullness in the chest that's not really like angina pain. It's different, but pain nonetheless. And then you see the pulsus paradoxus with respiration. They will have engorged neck veins. They can have a very labile blood pressure, meaning it'll go up and down. Again, that's pulsus paradoxus. It'll be high when they're relaxed, and then as they inhale, it'll drop down. And they will develop shortness of breath too. Again, they'll have that pericardial friction rub on assessment. So those are all things that you would want to assess for with a pericardial effusion. Pericardial effusions can eventually lead to cardiac tamponade. I've already talked about tamponade quite a bit. It's just the restriction of function due to excess fluid. Causes an elevation of pressure in all of our heart chambers. Causes a decrease in venous return and decreased cardiac output. So our cardinal signs of cardiac tamponade, which I've already talked about some, is a falling blood pressure, falling systolic blood pressure, and a narrowing pulse pressure where your systolic and your diastolic numbers get very close together. Typically, when you take a blood pressure and it is 93/82, we tell you to go recheck it. Position the cuff, check the patient, make sure their arm is not bent. Just go recheck it, because most of the time when you get a reading that close together, a systolic and a diastolic that close together, it's just a bad reading. The patient moved, or they have their arm bent, or the cuff is down on their elbow, or something like that. So you go check the patient, check the cuff, make sure all of those factors are eliminated, check it again, and if you end up with a very narrow pulse pressure, a very close systolic and diastolic reading, and they have a history of heart failure, then you know that you could be looking at tamponade. Okay? Another key diagnostic criteria, because you don't just diagnose it directly on that blood pressure alone, narrow pulse pressure alone, but you can, when you auscultate, their heart tones are very muffled. So you're not going to hear that good distinct S1, S2 that you would normally. You are going to hear this real muffled, distant. It's going to be difficult to distinguish, not a murmur, but just, you're listening to the heart tones through an accumulation of fluid, so they're going to be muffled, harder to hear. Medical management of tamponade is X-ray. We're going to be looking at structure. We're going to be looking for an enlarged silhouette, enlarged border, and that is not necessarily cardiomyopathy, but it'll be bigger because there's fluid accumulated around the heart. And then, of course, echo is the best non-invasive, most accurate or first line non-invasive test to look at the amount of fluid that's present around the heart and the degree of restriction. So once they determine how much it is, then we can do pericardial to aspirate the fluid away. We talked about that already too, about complications, coronary artery puncture, trauma, dysrhythmia. There can also be pleural puncture. They can pop a lung. They can cause pneumothorax. Or if they are aspirating toward the bottom of the heart, they can actually cause a gastric puncture, either in the esophagus or in the stomach. So those are all complications of pericardiocentesis, and our job during the procedure is to be there to monitor the patient for all of these problems. So if there was a coronary artery puncture, or if we did caused myocardial trauma, if the doctor, hit the heart, then you would see an arrhythmia possibly. You would immediately see changes in blood pressure and heart rate. If you popped a pneumo, of course, respirations and SATs would become altered. Gastric puncture might not be as readily observable. The patient might indicate pain, but they might be, they're probably going to be sedated for this procedure, so it might be something that is determined more gradually. You might see some swelling over the gastric area, maybe bruising if there is a hematoma formation or bleeding going on. And I've already talked about pericardotomy or pericardial window as the surgical treatment for tamponade. If they're having a recurrent pericardial effusions and recurrent tamponades, then a pericardial window is the treatment of choice. Our nursing care related to a pericardial window is just routine postoperative care that you would do for a CABG patient or for a patient having valve surgery, and then very close assessment to make sure that they don't have recurrent tamponade. Same with pericardial. If we participate and help with the pericardial, then our postoperative or post-procedure nursing care is close assessment to make sure they don't have a recurrence of the tamponade. All right, and another complication of end-stage heart failure is cardiac arrest, sudden cardiac death. So it's just, flat cardiac arrest, cessation of cardiac output because you don't have good pump function. It can be electrical in nature. A lot of times these end-stage heart failure patients have ventricular dysrhythmias very commonly, and so they can just go into a lethal ventricular dysrhythmia. Typically it's VFib. And that's it, sudden cardiac death. Other causes of cardiac arrest can be respiratory in nature, and that goes from the severe heart failure, or either right or left, especially left-sided heart failure. They get those severe respiratory symptoms, and then they go into respiratory failure. And once they get in respiratory failure and they become very acidotic, because the heart is impaired, they have such profound heart failure, they lose their compensation and they go into cardiac arrest. Okay, so of course we would want to initiate CPR immediately Chest compressions, defibrillation is always the first choice based on the rhythm that you see, but if there's no pulse, immediate chest compressions. And then early defibrillation if it is a shockable rhythm. If they are in a systole, of course we can't shock that, and so it's just chest compressions and following BLS protocol. Okay, so now we're going to move into chapter 30. I think this is the last chapter, possibly, of this lecture. I hope, because I'm getting just as tired as you are. Excuse me, I had to take a drink of water. So chapter 30 is just a little bit about assessment and management of patients with vascular problems and problems in peripheral circulation. Alright, our objectives here, we're going to just briefly review anatomy physiology that affects blood flow and tissue oxygenation. Really, I'm not going to do much about that at all. You're going to have to kind of do that yourself. Appropriate assessment parameters for peripheral circulation. Basically, in a nutshell, that is cap refill and pulses and skin color. Okay, so there you go. There's your review for that. And then we're going to talk about a few of these different problems and their causes, manifestations, and how to take care of them. Okay, the first thing we're going to talk about, the first disorder we're going to talk about is aneurysms. Okay? An aneurysm is a weakness in the wall of an artery. It's basically the same thing as a hernia. A hernia is a weakness in a muscle, whereas an aneurysm is a weakness in an artery. Okay? Can be caused by a lot of different things. It really, you can look at that material in the book. Chart 31.6 on page 868 gives you all of the different causes, different etiologies. Really, it doesn't matter the cause. The bottom line is that you have a vessel, an artery, that is carrying oxygenated blood, which means it's under high pressure. It's the high pressure side. It's got blood flowing through it, and there's a spot that's weak. It is a tire that has the great potential to blow out. Okay? So the etiology, the classifications really aren't very important. Knowing where the aneurysm is in the body, the location of it, and the size of it help you know your risk of rupture. And that's important to know because if it ruptures, your patient can die in a very expeditious fashion. Like it can lead them to bleed out, to hemorrhage, and they can flat bleed to death in a very, very quick amount of time. Okay? First type of aneurysm, well, here's some characteristics. Okay, you can look at this yourself. Basically, it's just showing you here that here's the wall of the artery, and you've got these different types of aneurysms where it might be on the outside of the artery, it might encompass the whole wall of that artery. Here we've got one on both sides, it bulges on both sides. This one splits. So like I said, the characteristics, the classifications aren't as important right now. Okay, the first type of aneurysm we're going to talk about is the thoracic aneurysm. These are located in the thoracic aorta, meaning anywhere from the aortic arch down to to the thoracic vertebrae end. Okay, so it's kind of location is determined by thoracic aorta versus or thoracic vertebrae as opposed to lumbar vertebrae. Okay, so from the beginning of the aortic arch all the way down to where the thoracic vertebrae stop is classified thoracic aneurysm or thoracic area. So an aneurysm in that area is a thoracic aneurysm. Alright, most of these are caused by plaque. Most of them are related to atherosclerosis. Okay? The most common site for a dissecting thoracic aneurysm the most common site for a dissecting aneurysm is in the thoracic area, and often they are fatal, because if you think about that picture I showed you earlier, where the balloon pump, the aortic arch and the balloon pump sits, aneurysms in that area are hard to fix. It's hard to get in there and correct them. And if somebody will remind me in class, I'll go into further detail about that, about how it's fixed. But thoracic aneurysms, it's very high pressure. There's a lot of blood being pumped out, and so a weakness in that area, if it ruptures, then they can lose a lot of blood very quickly. And if you remember that anatomy, that blood, it's feeding into the head, into the carotids. It's also feeding out into the body, and so it can be fatal very quickly. The most common signs and symptoms vary depending on location and how big it is. But the most common sign and symptom is pain. But it's a dull pain. It's very boring pain, dull pain. It's like a dull, nagging, constant. It's nothing that just really gets the person's attention and says, hey, pay attention to me, this is a problem. Okay? Most of the time, it's noticeable when they're laying down, when they're supine. It might only hurt when they're laying down. But again, it's kind of a dull, boring pain. It's nothing that really kind of gets anybody's attention. Medical management for thoracic aneurysms is surgery to try to repair or restore that vascular integrity. That area has to be reinforced with a graft, some kind of mesh or something to make that weak spot stronger. So again, we can talk more about that in class if y'all will remind me. But medical management is just, it depends on, a lot of times it depends on the size of it, and if the patient is symptomatic, and if it's getting bigger, if it's growing. If we have an aneurysm that we can tell is getting bigger in very short amount of time, then they will start looking at surgery. Okay? Blood pressure control is vital for not just thoracic but abdominal aneurysms too. Any kind of aneurysm, blood pressure control is vital. Capital VITAL. The more pressure that is inside the aorta, the greater the chance of that weak area blowing out. Okay? So the higher the blood pressure, the greater the probability of rupture. So, blood pressure control is key. And then with thoracic aneurysms, because most of them are related to atherosclerosis, prevention and reduction of risk factors is very important to prevent thoracic aneurysms. Okay? So think about all of your modifiables, hypertension control, diabetes control, cholesterol control, all of those things that are developing plaque in the coronaries can develop plaque inside the aorta, and then that plaque actually can weaken the vessel wall, okay, and lead to an aneurysm. Alright, the next type of aneurysm I'm going to talk about is an abdominal aneurysm, and that is the same kind of thing. It's a weakness in the aortic wall, but it is lower down in the lumbar region, so it is below the thoracic vertebrae, on down toward the renal arteries, okay, and even lower than the renals. Again, most common cause is atherosclerosis, so again, plaque. Incidentally, aortic aneurysms, abdominal aortic aneurysm, or AAA, You might see that in your charts at the hospital. You might see where your patient has a history of a AAA, that is an abdominal aortic aneurysm, are most common in white men. Okay, so for once, there's something that African American men are not at greatest risk for. Caucasian men do have the greatest incidence, and I can't explain why, other than, they have more rates of atherosclerosis, but it is much more common in white men, and abdominal aneurysms are more common in the elderly population. Most of them occur below the renal arteries. Okay, so if you think about anatomy and you think about blood flow, if the aneurysm is below the renal artery, then blood flow to the kidneys should not be impaired. But if it's an aneurysm that is either right at the level of the renal arteries or it's above the level of the renal arteries, then it can impair blood flow to the kidneys and it can put the patient into renal failure. Only about 40% of them cause any kind of symptoms, and the most common symptom is that when the patient lays down, and only about 40% of these have symptoms, but they lay down when they're supine. They say they can feel their heartbeat in their abdomen. They can feel or see a pulsating, throbbing mass in their belly. Now guys, do not freak out and go home and lay down, and if you can see your belly palpating, say, oh, I have a AAA, and freak out on me. Don't do that. All you skinny women, okay, and some of you skinny men too, if you lay down flat and you're very thin, you're going to see your belly pulsate. That's your aorta. That's what it does. When I say a pulsating mass or a pulsatile mass in an abdomen that is indicative of a AAA, these are people who weigh, 200 pounds, or a man that is, 6 foot 240. He's got a big belly, and when he's laying down flat, you see a pulsatile mass. That's what I'm talking about, okay? So if you come to class next week and you say, I laid down and I had a pulsatile mass, I have an aneurysm. No, you don't, okay? Let me just clear that up for you. So you have a patient in the hospital, he's a big fella, he's laying flat, and you notice a pulsatile mass in his abdomen, and he's got other risk factors for atherosclerosis, then yes, that is a true risk. Assessment findings, diagnostic criteria. Of course, I just said the key diagnostic finding is that pulsatile mass. They say about 80% of these aneurysms can be felt, meaning that you can feel, palpate a thrill. If you find it in just the right spot, you can actually feel that blood flow being turbulent through there. You can also auscultate a bruit. That's what a bruit is turbulent blood flow. So you could possibly, when you're auscultating for bowel sounds, you could possibly hear a bruit. That would never be a good thing, but it's possible. Ultrasound of the abdomen, CT scan are the two diagnostic tests. Ultrasound just gives us a good picture. CT is better because it lets us see how big it is. The actual size is going to be measured in centimeters. Length, and then the location, if it's high, thoracic, if it's around the renals, or if it's low, below the renals. CT scan is going to give us a really good picture of it, okay? Rupture is very likely in patients that are hypertensive and have aneurysms that are greater than 6 centimeters in size. So that's kind of how they determine whether or not we need to operate on them, is how big it is, and then if the patient has uncontrolled or difficult to control blood pressure, the bigger that aneurysm, the more likely they're going to have surgery. Medical management, keep the blood pressure under control. It's like I said before, blood pressure control is key. So we've got to control hypertension with whatever means we can. Okay, sometimes we're going to throw everything but the kitchen sink. Basically, anything that works is what we're going to use, but we got to keep the blood pressure within normal limits. Now remember, you don't want to drop them too low because then they don't have good perfusion. So it's that balance. Surgical treatment, surgical management is the treatment of choice for aneurysms approaching 5.5 to 6 centimeters. They're going to start talking about surgery. The mortality rate of a AAA is very low until it ruptures. And once it ruptures, the mortality rate spikes exponentially. Okay? They have a very poor prognosis if it ruptures. And so the key thing to remember is that you want to find it and treat it before it ruptures. Nursing management. What's our job as nurses? What's our role? Monitor, assess very closely, very carefully. If you know your patient has an aneurysm, okay, then you've got to be diligent about assessing blood pressure. You've got to be diligent about your abdominal assessment, looking for that pulsatile mass. You always anticipate rupture. You hope for the best. You hope it doesn't happen. Anticipate the worst. Hope it doesn't rupture, anticipate that it will. If that anticipation means you have a plan in place. You have an action plan in case it does. Signs of rupture or impending rupture are severe back pain or severe abdominal pain and an increase in that pulsatile mass. And of course, it would probably be associated with elevated blood pressure. So those are abdominal pain, back pain, impending rupture, and then indications of rupture is going to be very intense pain. Of course, hemodynamic instability, decreasing blood pressure, increasing heart rate, trying to compensate for the dropping blood pressure, a sudden drop in hematocrit, retroperitoneal bruising is what you're going to see first. And then a lot of times they'll get a hematoma in the scrotum area. They'll get a flank or a perineal hematoma. In men, they will often develop a hematoma around the groin, the penis, and the scrotal area. And then they will exhibit signs of heart failure because they have very poor cardiac output. If you think about it, that aneurysm is ruptured and all of their blood volume is spilling into the peritoneal cavity. Okay, so very thorough assessment and close monitoring and anticipating rupture. You will also see complications of that rupture being renal failure. Their renal, depending on the location. Even location doesn't matter once it ruptures. Once it ruptures, all their blood volume is spilling into the peritoneal, into their peritoneal cavity, so there's no perfusion, there's not any good cardiac output, and so renal perfusion ceases, and so urine output drops off. They will also develop ischemic bowel because there's no blood flow to the gut, and they can actually have an infarction in the bowel. So and then other signs of adequate perfusion are going to disappear. They're going to get pale. They're going to have poor cap refill, prolonged cap refill. They're going to get mottled. The skin is going to get very dusky and develop petechiae. It's just a bad situation. Rupture into the peritoneal cavity is very rapidly fatal in all cases. Okay, you don't have a lot of time. So our job as the nurse is close assessment and anticipation of rupture, communicating with the physician. Postoperatively, after repair, our job is also close and careful monitoring of all body systems, maintaining hemodynamics, keeping the heart rate and blood pressure adequate so that cardiac output is good, watching the EKG rhythm, monitoring fluid and electrolyte status, monitoring H&H, monitoring for renal perfusion, renal output, urine output, So, just close monitoring. Okay, another arterial embolic event that I want to talk about a little bit are embolism and thrombosis. Arterial embolism and thrombosis. Okay? Now this is more related to arterial clots, either in an extremity, or arterial embolism and thrombosis related to things like AFib, endocarditis, CHF. I've already talked about all of those things, but this would be a patient who throws a clot as the result of one of those chronic conditions. Okay? They can result from having an IV line in place for too long, a central line or a PA catheter, especially an A line in place. Remember we talked about placement of A lines, how you have to do the Allen test to assess for circulation. So it can result from a disease process, AFib, MI, endocarditis, CHF, or they can result from treatments, IV lines and procedures. Arterial clots can develop as a result of heart cath, PTCA, having a balloon pump in place. They can also develop, and I talked a little bit about this before, as the result of IV drug abuse. So, you kind of want to know your patient and their history. Symptoms, of course, depend on where it's at and the size of the clot, and whether or not it's obstructing blood flow to, a vital organ system. Symptoms also depend on whether or not there is good collateral circulation. So if we're talking about a blood clot in a radial artery from an A line, if they have good ulnar artery circulation, good collateral circulation there, then integrity of the hand will probably be okay. But if they don't have good ulnar artery circulation, then integrity of the hand is, can be compromised. So you really have to do a lot of good assessment there. You also, the key thing to assess for is loss of blood flow, loss of circulation distal to wherever the embolus is. So assessment is vital in this situation. Okay. Very acute, severe pain. They're going to gradually lose sensory function first and then motor function. Motor is the last to go and the first to come back. Okay? Sensory is the first to go. I think I just said that backwards. They're going to lose sensory and motor function. They will get motor function back first. So motor is the last to go and the first to come back. Okay, that is correct. So they're going to notice changes. You're going to notice changes in your assessment in those 6 P's, okay, of circulation. Pain, pallor, pulselessness, paresthesia. There is a word poithermia, or I can't say it. P-thermia is my abbreviation for it, and it stands for temperature or coldness, and then paralysis. So when you're assessing your patient in their extremity, you're looking for pain. What color is the skin? Do they have good capillary fill? Do they have good blanching, or is it pale? Do they have pallor? What is the quality of the pulse? Do they have any paresthesia, which is numbness, tingling? Is the extremity cold or warm? And do they have any paralysis developing? Okay, so the 6 P's of circulation are the vital things to assess for. Of course, diagnosis is based on the sudden onset of symptoms. Is there an apparent source of the emboli? If they're in AFib, then we're going to, probably say it's related to that. Doppler flow studies to look at circulation, angiography, arteriography. Those are done in radiology or in the cath lab. Those are dye flow studies of the extremity to try to figure out how much blood flow is getting to the distal area beyond the clot. So our nursing interventions related to dye study is the same as with heart cath. You have to know what the patient's allergies are. You have to know what their kidney function is. We're using dye, so all the same rules apply. Okay. Medical management for an acute arterial occlusion is going to be aimed at restoring blood flow. Okay, time is critical. We've got to get flow back to that extremity or that area. So an embolectomy is going to be the treatment of choice. It is the first choice if we think that extremity is viable. Okay, and that's just an embolectomy just means they do a surgical incision into that vessel and they actually try to remove the clot if they can get to it. Okay, if it's been too long and we don't think that that extremity is going to be viable, means we're going to be able to save it, then they might talk about amputation. Endovascular management is similar to heart cath, but it's where they go in and instead of doing the coronary arteries, they will actually do runoff studies and try to see how much blood flow is there, and then they can do stenting and other types of procedures similar to what we would do for coronary arteries to try to restore blood flow to that extremity. But embolectomy is the treatment of choice for an acute arterial occlusion because it's the quickest. Okay, time is critical. Other management pharmacologic therapies that you might see, of course, anticoagulants. We're going to load them up on heparin. Again, bolus them and then an IV infusion and checking PTTs every so often. We might do intra-arterial thrombolytics. They might go to cath lab or radiology. We might isolate the location of that clot, and if we can get in there, we can directly administer TPA or another form of thrombolytic directly on that clot to dissolve it. You need to be aware of contraindications to thrombolytic therapy. Why would we not want to give our patient thrombolytic therapy? When is it okay and when is it not okay? Okay, and then safety measures. Our nursing management, bed rest. We want to elevate that extremity. This is always so funny to me. Slightly elevated, elevate or slightly dependent. Okay, well, the bottom line is that you're going to position that extremity however you need to promote good blood flow. Okay, if elevating it makes it pink up, then leave it elevated. If dropping it down a little bit on the side of the bed makes it pink up, then that's what you do. You want to keep the extremity warm, not cold. It might be cold, but you want to try to keep it at room temperature because the colder they are, the more they're going to vasoconstrict. Plus, they probably, if they're having acute occlusion, they have some numbness and tingling, and they're not going to be able to tell if their hand is super warm or super hot. Super cold or super hot. So they have that impaired sensation. So you really want to try to keep them at room temperature. You've got to protect that extremity from injury, from shearing and trauma, because they're, again, they have that reduced sensation. These patients need continuous monitoring. Often they are on step down or in ICU just because it's such a critical blood flow issue. Of course, bleeding precautions with thrombolytic therapy. Again, you need to know with TPA, you need to know when is it okay to give it, when is it not okay to give it, contraindications to TPA, and then safety precautions after the fact, nursing assessment after the fact. And then after our procedure, after our embolectomy or whatever we're doing for this patient to restore blood flow, our post-operative care is aimed at getting them up, getting them moving around. We don't want another clot to form. We want to do some very thorough patient education on prevention. If they're going home on anticoagulant therapy, we've got to do education about safety and bleeding precautions and, all that stuff that we've already talked about in the past. So just a lot of good patient education here. Okay, well, this is the end of this marathon 2-hour and 40-minute lecture that covers 4 chapters. So congratulations, you survived, and make sure you write down your questions if you have any, and we will go over them in class. Thanks.